strikingly new. There's just a lot of accumulating data, and that the data is very consistent. When treating a non-left main lesion, you should use physiology to decide whether or not the lesion is severe enough to treat, and you should optimize the result with intravascular imaging, either IVUS or OCT. When treating left main lesions, you can use imaging or physiology to decide whether or not to treat, but again, you should optimize the result with either IVUS or OCT. I will share with you maybe just a couple of data points. The two largest IVUS studies, randomized studies, were IVUS XPL in Korea and Ultimate in China. I worked with both investigators to merge the patient level data, and with IVUS guidance, mortality was reduced by 50% consistently over time, which simply means that your patients will live longer if you do IVUS guidance when stenting lesions that are at least 28 millimeters or longer. In terms of left main intervention, there was a report from the UK. This is a National Society registry showing that IVUS guidance left main intervention reduces mortality by 34%, and especially in the hands of interventionalists who do the most left main PCI procedures because they know how to use the data. So we have randomized trials, meta-analyses, registries, all supporting what I said in the beginning. Coronary calcification is probably microscopically present in everybody. It reaches the threshold when it impacts on PCI procedures. And we've known that for years. But what we haven't done is developed algorithms or scoring systems to say when you must use some kind of plaque modification devices. And I won't get into which plaque modification device, but we published the first scoring system, which is an OCT scoring system, showing that we call it the rule of fives, or 50%. More than half the circumference, more than 5 millimeters in length, and more than 0.5 millimeter thick will predictably limit stent expansion. Now, what about IVUS? Well, we have a paper that was submitted to Circulation Intervention, and we're now, if you will, arguing with the referees. And so we now have an equivalent IVUS scoring system that includes circumferential calcium, more than 5 millimeters of calcium that's at least 270 degrees or 3 quadrants, the presence of a calcified nodule, and vessel size. Now, when you have that combination, again, if you have any two of those, predictably you get stent under expansion. This issue of calcified nodules is becoming increasingly important and perhaps increasingly prevalent as our patients get older. Patients who have lesions, whether they're stable or unstable lesions with calcified nodules, do not do well after PCI, and we don't have a great strategy. There are many ways that you can use IVUS. As typical of most procedures, IVUS can help throughout the procedure. So in terms of CTO specifically, it can help you to identify the proximal fibrous cap, which is often ambiguous, both in terms of its axial location as well as circumferential location. It can tell you whether or not you have crossed the CTO, particularly antegrade, and have stayed in the true distal lumen, the true lumen distally, because if you stent into a false lumen, you don't get myocardial perfusion and the patients don't do well. It can assess the complications, perforation, dissections, intra and extramural hematomas. and it can tell you whether you have properly implanted and sized and expanded the stent and got a good result from the stent part, which is obviously the end of the procedure. So it can help throughout the procedure. And we have data, we have randomized trial data that IVUS guidance reduces events at 1 year of follow-up by 75 to 80%. So it can help at many, many, many steps of the procedure. And it depends a little bit on what your procedure is. For example, if you decide to do a retrograde procedure as opposed to an antegrade procedure, it can help to identify the retrograde wire in the false lumen and where you should connect it to by aggressive dilation. And then you can prove that you've entered the true lumen after aggressive dilation. So, as I said, there are many, many ways that it can help.